Right, okay. So welcome to the, I think this is the 19th session, as far as I remember, right?
Yes, sir. 19th session.
19th session, yeah. So good, right. So basically anemia in pregnancy is a relatively simple topic if you just look at 90% of the problems. 90% of the patients who come to you with anemia is due to iron deficiency anemia in pregnancy. Okay, so it makes the matter relatively simple. All the rest are 10%, right? So basically, the chances of you meeting any other type of anemia, of them 5% is folate deficiency and B12 deficiency, right? B12 deficiency is very rare, right? And they cause, as you all know, megaloblastic anemia, right? You will see megaloblasts in the blood. So, so 5% will be taken up with folate and B12 deficiency, which is called megaloblastic anemia. Okay. The rest of the 5% are the rest of the things that we, what are these? Problems with hemoglobin, right? And problems with the bone marrow or the problems there, right? So inherited disorders and the problems with hemoglobin. So those are the other anemias which are rare. So I'm not going to touch those today, right? Maybe at a later date, we'll talk about thalassemia, we'll talk about the hemoglobinopathies, right? We'll talk about those because thalassemia in pregnancy is completely, it's highly unlikely that you are going to meet it, right? So we'll have to speak about the alpha and the beta thalassemias, all that. So those we will have a chat at a later point. So today we are going to concentrate on a very relatively simple topic, which is called iron deficiency anemia, because 90% of the, I'll just touch on folate and B12 deficiency as well. But most of the anemias that you all are going to meet are iron deficiency anemia, right? Is that clear? Okay. So let's look at the definition, right? If you look at the definition in pregnancy, now the problem when you look at iron deficiency anemia, there are lots of things you can have to look at, right, to arrive at a diagnosis actually, right? You need to exclude other things, and there are certain indices that needs to be checked. Very roughly, we look at iron deficiency anemia by just looking at the hemoglobin concentration, right? And there are several problems with the hemoglobin concentration. It is not an ideal way to look at the iron deficiency anemia, okay? Because there are different things. Ideally, what we should be doing is checking the serum ferritin, right? So ferritin, if the ferritin stores are low, right? We are looking at the storage capacity. If the ferritin is low, right, which is less than 12, then we actually diagnose iron deficiency anemia. So it is a bit, but the problem with ferritin is that it is expensive. Okay, so actually and probably not actually necessary for us to do that. So therefore, if you are looking at a woman who comes to you, right, and say in the preconceptional period, and you really want to see whether the stores are low, right, and whether there's a possibility of her having anemia in the future in pregnancy, yes, maybe ferritin is indicated, right? And it is thought that we need to give treatment to her if the ferritin is lower than 30, right? So any woman who is coming to you in the, this is the ideal setup, right? Hardly ever, only few women will come to us with symptoms of anemia, or hardly any woman will come to us for screening for their iron stores or even before. But however, for some reason, if we do that and if the iron stores are less than 30, it is thought it is better to treat the woman with iron therapy to get her stores up, because if the stores are very low by the time she starts, then the pregnancy or repeated pregnancies can cause anemia and problems, right? So that is one thing. So definitions for the moment there are different definitions of anemia, and we simply at the moment we just look at the hemoglobin concentration, right? Now the hemoglobin concentration by the WHO, it is 11 grams per deciliter. Under that, which is called anemia. However, different countries, even USA, different countries, and probably in Sri Lanka as well, we will look at anemia by looking at the 10.5 milligrams per deciliter mark, right? Which seems to be more practical because we'll be diagnosing a huge number of patients with anemia if we just take the cutoff mark at 11. I personally, I would even consider 10 grams per deciliter all right, as a cutoff mark for anemia. Okay, so that is the diagnosis. But if you actually look at it, if you really want to diagnose iron deficiency anemia, it's better look at the ferritin levels, right, which will give us an idea of the stores, and NT less than 12 is diagnostic of iron deficiency anemia. Is that clear, children? Right. Now, why is this important? Why is anemia and pregnancy important? Actually, not much data. Iron deficiency or low hemoglobin concentration, right? The actual definition, if you are looking at, is the reduction in the oxygen transporting and carrying facility of the blood is called anemia. Okay. So now, because the oxygen carrying capacity, because the tissues needs oxygen, number one. Two, iron is required in iron containing enzymes, which works with the muscle. There are iron containing enzymes in the muscle. There's iron containing enzymes in the epithelium. There's iron containing enzymes in the nerves, right? So for all the systems to function, we require iron containing enzymes. So that is why it is thought universally, if there is low iron stores, right, all these things can malfunction. Labor can malfunction because the muscle is involved, the nerves are involved, right? Different kinds of intersurfaces can malfunction because the epithelium and the intersurface require iron containing enzyme. So therefore, overall, the whole body can malfunction if the iron stores are lost and anemia. However, there seems to be no direct relationship, or most of the studies that have been looking at anemia and outcomes or bad outcome in pregnancy does not give a very tight association between these two. Probably because there are so many other associated factors which have not been looked into, right? So mainly, if you look at what problems with anemia is, it is thought for the one problem that is highlighted is preterm labor, and the baby, if born preterm, has lots of problems, right? The second thing that is a possibility is intrauterine growth restriction or small for gestation, right? So those are the two conditions which have been associated with this. The third problem is, if she goes into labor, right, and then she has a postpartum hemorrhage, the chances of her compensating or coming out of the postpartum hemorrhage safely may be dependent on the hemoglobin concentration which she has. Because if she is very anemic to start off with, she will decompensate very quickly, right? However, that association is also not very well established, saying that, okay, all anemic women will fare very badly in postpartum hemorrhage, right? So all these associations do not have direct evidence or huge amount of evidence to support that just because we get the iron stores up and just because we get the hemoglobin up over 10.5 or 11 grams per deciliter, it reduces the number of preterm labors or small for gestational ages or bad outcomes in postpartum hemorrhage or overall enzymatic problems and overall problems in pregnancy. So there is no direct evidence. But however, logically, especially when we look at if she starts off with, it is logically understood, if she starts off with anemia, there's reasonable grounds for us to decide or think that if she has a postpartum hemorrhage, she'll be worse off, which you know. That association is there. Okay. So that is why it's important. For the mother, it is important, right? Is thought that overall well-being is better off, right? Second thing is she can become, she may be symptomatic with anemia, but all the rest of the factors contribute as well, right? And therefore, putting up the iron stores may be beneficial for her. For the baby, it is not directly thought that it decreases preterm labor. It is not directly thought, it is not thought that increase in the iron stores will decrease small for gestational age. So there is no direct association shown in trials, but it is also postulated that that is there, right? So that is why the iron deficiency anemia, that is why we think treatment is probably beneficial, although we do not have a huge amount of evidence to support that, right? Okay. So that is the necessity. Now, if you look at all the physiology, what happens during pregnancy? Okay. First of all, the plasma volume will increase by about 50%. Overall, about say 1.5 liters will increase in the blood, right? Plasma volume. The hemoglobin also, because of erythropoiesis, right? Hemoglobin also will go up, but that goes up by about 25%, right? So relatively, because the volume goes up more than the hemoglobin concentration, relatively there's hemodilution during pregnancy. You all understand? So if the plasma volume goes up the same amount and the hemoglobin also goes up by the same amount, the hemoglobin concentration would remain the same, right? However, the plasma volume goes up more and therefore the hemoglobin concentration, because the what it is, red cell mass, actually not the hemoglobin, red cell mass increases by about 25%, and therefore relatively there is hemodilution and the hemoglobin concentrations will fall. Do you all understand? So that is why in a normal person, there's a wide variation, right? We can even go up to about between 12 and 15 grams per deciliter can be considered normal, right? But in a pregnant woman, 11 is okay, even 10.5 is okay, or anything over 10 is also considered normal. Do you all understand? Right. So when there is anemia in pregnancy, right? Now it's very difficult to look at plasma what it is, volume in pregnant women. But if you are going to look at iron deficiency anemia, what happens to the hemoglobin? It decreases. It decreases a lot because even with hemodilution, it decreases. But that is why we have brought the norms down to 11 to 10.5. Is that clear? If it goes below that, it is called, we think it might be iron deficiency anemia. Is that clear? Right. Then what happens to when the hemoglobin concentration goes down due to hemodilution? The hematocrit or the concentration of the blood also goes down, right? Because there's hemodilution. Is that clear? So one of the indices that it will go down is the hematocrit. The other is the hemoglobin, right? Which goes down naturally. However, if she comes down to the anemic range, then the hematocrit might go down further. Is that clear, children? Right. Then what happens to the mean corpuscular volume or the MCV, right? Normally in pregnancy, what happens is the MCV will go up. What is the reason? Because it looks at the volume of the cell as well, right? Now, what happens is, because there is erythropoiesis, because erythropoietin is stimulated, so there is more erythrocyte production, right? And there are immature forms as well, and therefore they become slightly larger, and therefore the MCV during pregnancy will go up. So what happens is in anemia, right? So MCV in anemia, because there is not enough iron, right? The MCV might fall, but it's very unreliable just to look at an MCV, right? And say, okay, she has iron deficiency anemia is not a very good thing because it's unreliable. But in normal pregnancy, the MCV will go up, okay? But in anemia, the MCV might fall, okay? But however, this fall is not significant enough for us to diagnose. Just looking at MCV alone, iron deficiency anemia in pregnancy. Is that clear, children? Right? Any questions there? Okay, right. So what is the take-home message? We just do not look at MCV in pregnancy and diagnosed iron deficiency anemia. Is that clear? So normally it goes up. In in anemia, iron deficiency, it goes down. But that going down is not significant enough for us to diagnose iron deficiency anemia. Is that clear? Right. Next is the mean hemoglobin concentration, right? Corpuscular mean MH mean mean corpuscular hemoglobin concentration doesn't make, there's no difference, right? It just stays the same. So in pregnancy it's same. So it's not a very good indices for us to look at, because during pregnancy it does not increase or decrease. So it does not really give us a very good idea as to what happens to it. So therefore we really don't look at when you look at the when we are trying to diagnose iron deficiency anemia. Is that correct? Right. Then what are things that goes up? The total iron binding capacity increases in pregnancy. Right? Why? Because in the blood, remember, the iron is carried to its tissues by a transport molecule. What is that called? That is called transferrin, right? So in pregnancy, what happens is, because the iron needs to be taken to all the tissues, because the fetus requires iron, the placenta requires iron, the tissues are growing, right? So there are lots of things happening in the uterus, right? So therefore, the total iron binding capacity has to go up because the transport needs to be very good, right? So if you look at the total iron binding capacity during pregnancy, naturally it should go up, right? But if you look at it in anemia, that will go down. So, but still, if you look at TIBC, right, it is also not very reliable for us to diagnose iron deficiency anemia. Is that clear, children? Right? So that is one thing that you will have to look at. Okay. Then serum ferritin. What happens in pregnancy? The serum ferritin concentration will serum ferritin concentration will also go down slightly because of haemodilution. But if it goes below 12, which is the diagnosis, and normally it's between 15 and 300, right? If it goes below 12, then it is diagnostic of iron deficiency anemia. Is that clear, children? Right? And what is the other indices that we look at? Is serum, one moment. Okay. Baba. Ani mara wakraya gyan dena. Hello? All right, okay. Why all this time? Okay. Right, okay. Thanks. Okay, right. So where were we, children? Total total, did I speak about all the indices, right? I spoke to them as to what happens in pregnancy, and I told you what happens to them in iron deficiency anemia. Okay. I did not speak of one thing, serum iron. Did I speak of serum iron? No. The serum iron, can you hear me? Yeah. The serum iron comes down during the normal physiological pregnancy. Why? Because the serum iron is bound, because the total iron band capacity goes up and the serum iron comes down. And it also comes down due to haemodilution, right? But if you look at it, if you look at iron deficiency anemia, then the serum iron goes down below 12 as well. Okay, so therefore, everything basically falls in iron deficiency anemia, right? But if you look at a normal pregnancy, there are some things that will increase. Total iron binding capacity will increase, and the mean corpuscular volume will also increase in normal pregnancy. The rest of the things will fall due to haemodilution. Ferritin will fall, hemoglobin concentration will fall, right? Mean corpuscular hemoglobin volume will be the same, right? Almost same, right? So those are things that fall. Two things go up, the rest of them fall. But in iron deficiency area, everything falls. Do you all understand? So that is how we make a diagnosis. So basically, what do we do to make a diagnosis, right? So we try to screen people. We try to screen our pregnant women to try and come to a diagnosis. And when do we screen? When they come to us for our booking visit, we do a full blood count. Okay, and then we can diagnose anemia as they come in, and then we can initiate treatment. Okay, the next full blood count which we do along the way, if necessary, if she is symptomatic, we can do, but otherwise routinely for screening, we do it at 28 weeks. Okay, and then we can initiate some form of treatment if necessary. Okay, right. So remember, booking and at 28 weeks, right? That is the screening process which we do, where we can initiate treatment. So now, if we diagnose these things, right, there are things which you can do. Now let us look at two concepts which we need to understand as doctors, right? In Sri Lanka, one moment. In Sri Lanka, all right, there are two ways of thinking about this. Okay. In most countries, treatment is initiated with a diagnosis of iron deficiency anemia. What does that mean? There is no universal supplementation of iron and folate. Okay, so in the first full blood count, if the iron and the indices for iron deficiency, right, are normal, and if there's no diagnosis of iron deficiency anemia, then there's no requirement for treatment, because their daily food intake and daily iron intake is probably enough for them to have brought to this, to have come to this level. So usually that is done, and because of that, serum ferritin is done routinely, but to us it is an expensive test. Okay, but if you look at it that way, to supplement iron to a lot of women, right, would be more costlier probably than just a serum ferritin at the beginning. Okay, but then the other concept is, right, so if there is iron deficiency anemia at the beginning of the pregnancy, then you treat, right, and there is therapeutic kind, and then you give iron supplementation. Is that clear? Right, during pregnancy. The other way of looking at it is, if the whole country, there's a lot of women with anemia, or they go into pregnancy with low iron stores, right? The other concept is universally give everyone iron, okay, which is called universal supplementation, which is one of the concepts our country is going with, and probably a lot of Asian countries are going with the same concept, okay, is where a large number of the population of women who are in their reproductive years may be having iron deficiency anemia. Remember, B12 deficiency is rare in pregnant women. Okay, why? Because B12 deficiency is also tied in with infertility. So women who are very much B12 deficient normally do not get pregnant. And therefore, women who get pregnant usually have adequate stores of B12. Okay, so that is one thing that you will have to remember. So, but those are rare ones which I told you. I just remembered it, that's what I told you. Now, let's get back to iron supplementation, right? So therefore, all the evidence suggests routine iron supplementation or universal iron supplementation has not found to be very beneficial, right, as far as the outcomes are concerned, and it should not be generalized for everyone. But these policies are taken in different countries at different levels depending on their population, right? So therefore, for the moment, our country is thought that a lot of women are anemic before they come into pregnancy, and therefore routine iron supplementation is still recommended. But remember, that is not the rule, and that is not something that is recommended by all countries. Is that clear, children? Right. Now, let's look at how I have taught you. I told you what happens in normal pregnancy. Okay, to recap, I've told you how it is diagnosed by hemoglobin, although ideally ferritin probably is a better way to look at it, right? Less than 12. Then I have told you the diagnosis I have told. Then I have told you about the importance. Remember, two things you have to remember, children, as MBBS. What? Preterm labor and small for gestation or IUG. It's a possibility. So, and the babies, if the baby is born with preterm labor, then of course all the problems with preterm labor is there for the baby as well. And then the other thing is, if she goes into postpartum hemorrhage, if she's anemic, she might be worse off than. So those are the three important things that you have to remember. And of course, in breastfeeding also, she will require good stores of iron in the future, right? Now, that is the importance, right? Then I told you about the position or two different concepts. One is treat only patients with iron deficiency anemia, right? Which is more taken up by countries who do not have a large population of the women are not anemic, and they have good iron stores. And in countries where the population of women who are going to pregnancy has a lot of anemia, routine iron supplementation may be advised, like in our country. Is that clear? Right. So now let's get on to understand how it's treated. Now, basically, treatment or even routine iron supplementation is what? Only three things. We can give it orally, we can give it parenterally, which is intramuscular and intravenous, right? And we can give blood. And the number 4 is we can give erythropoietin analogs, things that work like erythropoietin, right? So, and of course, those are the 5 concepts of increasing the iron stores or reducing anemia in pregnant women, right? So those are the concepts. What are these? You can give iron orally. 2, you can give parenteral iron, which is intramuscular and intravenous. 3, you can give whole blood. 4, you can give erythropoietin. Okay. So those are the that's I say, right? Oral, intramuscular, intravenous, that is parenteral. Then you can give whole blood and you can give erythropoietin. So those are the 5 ways of giving blood. So that's why I said anemia is not very difficult. Okay. Now let's look at a few small concepts which I want you all as undergraduates to understand. if you are giving iron, oral iron children, right? The amount of, if you give, now, the requirement that you need to give, right? The best ways of giving iron, right? There are different ones. There are ferrous based, there are ferric ones, right? So the best, if you look at all these, are iron that is given in the way of ferrous. Okay, the ferrous based ones, ferrous fumarate, all those ferrous based ones are the ones that increase or better way to give than ferric. So the recommendation is, if you are using iron supplementation, use ferrous. Is that clear? The second concept you have to understand is there are lots and lots and lots of products in the market. Okay. However, most of them are almost the same, right? So the requirement is you give between, say, 65 or 100 to 200 milligrams of elemental iron per day. That is the requirement. Okay. And so therefore, that must be given because the absorption is always low. However much you give iron, the absorption does not increase so much in pregnancy. The absorption is slightly high only. Okay. And it is thought that if you, or evidence shows that if you give vitamin C along with it, it increases the absorption to a certain amount. However, most of that evidence is for orange juice. The normal thing is you take some orange juice, fresh orange juice, right? And iron. Okay. There's not much evidence about the combined preparations of iron with vitamin C. Not much, right? So remember, all the hype about promoting these may not be exactly. So it is not really thought, even if you combine, put a bit of vitamin C into the iron and give it as a tablet, that is going to increase the absorption, right? What is definitely known is if you give calcium and iron together, it will reduce absorption. So you have to give it apart. If you give iron in the morning, you have to better give calcium in the night. Or if it is calcium in the morning, iron in the night, or the other way, right? Apart. But remember the vitamin C. The second thing which you have to understand about the concepts of delayed preparations, they say, okay, because one of the biggest problems of giving iron are their gastrointestinal symptoms, right? 40% of the women will have some, almost all, but severe ones will be in 40% of the women who take iron supplements, right? They will have gastric irritation, they might have constipation, they will have nausea, vomiting, discomfort, all that will happen, right? And then the person will come and promote you, look, doctor, this is slow release. So iron doesn't get released at once, and so the gastrointestinal side effects are less. But what is the actual science behind it? They give a slow release, so the iron is released slowly. But by the time that thing starts to release iron, it has passed the duodenum. Okay, duodenum is the place where most of the iron is absorbed, right? So therefore, it has passed the duodenum and it releases it below, but there is no absorption, not much absorption. So why are the gastrointestinal symptoms reduced? Because absorption is low, right? And there's less iron actually in the tummy, right? And therefore, definitely GI symptoms will be less, right? So please remember that usually the gastrointestinal symptoms are directly related to the amount of iron that falls into the tummy. Do you understand? So if more falls, the woman will have more intestinal symptoms. So the myth about slow release tablets needs to be, or the hype or the sales, the sales talk about these slow release tablets or layer by layer release, all this will reduce gastric symptoms is not entirely correct, because the reduction in the symptoms is basically not because of there's low absorption and low release. Do you understand? So that does not convert into better absorption in patients. Okay. So if you give 100 to 200 milligrams of elemental iron per day in a capsule or whatever, right? The hemoglobin will normally go up by 0.8 grams per deciliter per week. Okay, you understand? So if you give it therapeutic dose, right? However, you can also, the other concept is you give a lower dose of iron, right? 65 milligrams of elemental iron throughout the pregnancy as a prophylaxis. So lots of thoughts as to what we give, right? And therefore, remember, although we might give a small amount, right, the absorption may be high in some people. Even if we give a lot, the absorption may still be the same. All these combining things may not be, it's not very much evidence-based, right? And the slow release preparations may not, because by the time they start releasing that, they are past the duodenum where the absorption is the highest, right? And therefore, really, there's not much absorption. So all this needs to be considered. So if you are, remember, if you are giving oral supplementation, children, ferrous ones are the best, right? And then, so those are the things that you need to remember. Is that clear? Now, this is all right if we start these off in the initial first 12 weeks of pregnancy, okay? Or initially, because there's time for the hemoglobin levels to go up to our desired level, okay? If we are in a hurry and there's not much time for us to sort things out, we might think of intramuscular and intravenous ways of giving iron, okay? Now this intramuscular is not very, we don't get many preparations. Intramuscular is not very popular because one is it's very painful, right? And therefore the absorption may be erratic as well, and therefore it is not. Intravenous was a bit popular some time ago, right? There are some units that practice it, some units not. Now those old iron dextran solutions, right, which we used to use, right, are no longer very much advocated to be used, right? I really don't know whether they are now arriving as well, right? Because in our unit at Kalubali, we don't really use intravenous iron in pregnant women. Non-pregnant is a different story, okay? So there are newer ones, right, which can be used intravenous, right? Please find out their names. And a total body dose can be given in one shot, right? So it's a quicker way of getting the iron stores up. It's a quicker way of doing that. So which may be a good way if you don't have much time, right? If you don't have much time at all, the best way is to give blood transfusions, right? So if you are looking at 36, 37 weeks and she's very anemic, right? There's no way which we can give all these things and get the hemoglobin or reduction in the anemia. So therefore, we might need to give blood products. So the problem with blood, it is tied on to a lot of problems, right? There can be diseases that goes with it, even if it is tested. There are different types of new diseases which we really do not know, right? Which are called virions. We do not know. These particles, we do not test for them, right? So different kinds of protein particles can enter the blood, and it can give long-term consequence, which we do not, because we test it for a few diseases, right? HIV, hepatitis B, Hep C, all this. So it's a limited amount. But there are other diseases which we still do not know about, which are communicated from one person to the other through things which may still not be tested for. So long-term consequences may be there for blood transfusion. So therefore, we have to remember blood transfusion should be the last resort. However, if we don't have time until delivery, then we might resort to blood transfusion. Okay, so if you are given a patient, say at 36 weeks or 37 weeks with a hemoglobin of say 6, Of course, there's no time to give her iron supplementation and try and get the hemoglobin up until delivery. So you might require to do a blood transfusion, right? And then next comes our erythropoietin or erythropoietin analogs, right? What does erythropoietin do? It goes, it's produced by the body, right, normally. But erythropoietin will increase the erythropoiesis, okay? Usually it is reserved for women who are having chronic renal failure. Chronic renal failure women due to the kidney failure, right? Because it is produced in the kidneys and slightly higher, right? You know that. So if there is overall failure of the kidney, right? What happens is what? The erythropoietin falls. So in women who are having kidney problems, chronic renal failure with pregnancy, there is an anemia reduction in erythropoietin production, and therefore throughout the pregnancy, erythropoietin can be used to reduce the anemia in these patients. Do you all understand? So it has been tested very successfully, and it is indicated to keep the hemoglobin levels high throughout the pregnancy in women with chronic renal failure. In women who do not have chronic renal failure, normally erythropoietin is not indicated. However, there are studies to show yes, you can give erythropoietin for pregnant women without renal disease as well. But these studies are limited and probably maybe it's not a very accepted, although there are some units who may be doing, but it's expensive, number one, right? Number two, you need to concurrently, you have to give iron, preferably intravenous iron, concurrently with treatment, because if we give erythropoietin, for erythropoiesis, there has to be iron stores as well for them to, for the body to produce our erythrocytes, right? So therefore, concurrently intravenous iron also is we will require to give it, right? So basically, remember as MBBS doctors, these are the 5 concepts that you need to understand. If it is in the earlier part of pregnancy, then you talk about iron supplementation, of which 100 to 200 milligrams of elemental iron, right? Which can be given as a daily dose. The ferrous ones are the best, right? Ferric ones are inferior, that is evidence-based. There is no evidence for the moment to tell us that all the pregnancy outcomes are better off, right, by giving universal iron supplementation. However, this can be recommended. Iron deficiency anemia also can be treated, but still there is no 100% association between the outcomes are becoming better. Is that clear, children? Right? So initial stages, iron supplementation. Some intermediate, we can think of parenteral, right? If it is erythropoietin, remember it's for patients with chronic kidney disease whose erythropoietin production is low. You can give it throughout the pregnancy, but sometimes you might need to put in intravenous iron in conjunction with the erythropoietin. And for the latter stages, if they're very anemic, then of course, blood transfusion, but it has its negative side to it as well, right? So those are the things that you have to understand about anemia. Okay, so that is iron deficiency anemia, right? The next part is what you have to understand is about folate and vitamin B12 deficiency. As I told you, vitamin B12 deficiency is rare. Most of the time, if we find the megaloblastic anemia, right, where the things are large, right, chances are it might be folate deficiency. Okay, so therefore, but measuring B12 and or folate in pregnancy in serum is quite expensive and is not very very standardized way, because in pregnancy all these investigations may not be very reliable, right? So how do we prevent that than to treat folate deficiency? Yes, because there may be other times like beta thalassemia also might give it, right? So therefore we have to be very careful when you make the diagnosis. Maybe we can make it in conjunction with the hematologist, but before treatment we need to understand that folate supplementation is given. Now folate deficiency happens because the requirement for folate goes up. Okay, the placenta utilizes because dividing tissues. The baby is growing, so we'll require folate. All the uterus, the placenta, the increased cell mass, right? In the mother, everybody uses folate. So therefore, the folate consumption also goes up, and therefore folate deficiency might occur, right? So I forgot to tell you, normally in the first trimester, I'm talking about iron again, the requirement for iron is 2.5 milligrams per day in the first trimester. By the end of the third trimester, it goes up to 6.6 milligrams per day. Okay, that is the requirement per day. So therefore, for the total of the pregnancy, the requirement is 700 milligrams to 1,400 milligrams for the whole pregnancy, right? So that is why sometimes if the food is not, giving the woman enough, we might need to supplement. Getting back to folate, right? Because the consumption is high, we need to give. So therefore, initially, remember, folate also has a role in what? In the proper formation of the neural tubes. This is 100% evidence-based, right? There's good evidence for it. You need to give folate supplementation of about 400 micrograms per day, at least 3 months prior, right, to the pregnancy, and it needs to be carried out up to 12 weeks of pregnancy. Why 12 weeks? Why not beyond that? Because the neural tube closes at 12 weeks. So before the most of the neural tube will close at 12 weeks in the formation of the fetus, right? And therefore, the folate of, when you give folic acid or folate, it acts, or there should be enough until the neural tube closes. If there's a deficiency, there are neural tube defects, right? Which means it doesn't close up, and that happens at 12 weeks. So therefore, we need to give the folate up to 12 weeks, and you can stop beyond that. So the requirement is 400 micrograms per day, right? If there's a deficiency, you can increase it to about 800 micrograms if you want. But most of the tablets in Sri Lanka test 1 milligram, which is 1000 micrograms, which should be enough, right? So that is about folate deficiency. So diagnosis maybe by blood picture, maybe you might look at the megaloblasts themselves, maybe we really don't do bone marrows, right? You can look at the serum folate, but those are not very reliable. So might as well as treat it, because you can give folate during pregnancy without a problem, right? Vitamin B12 deficiency is extremely rare, as I told you. Vitamin B12 has a bit of infertility associated with it. So usually women with infertility with vitamin B12 deficiency might not conceive. So therefore, it is a bit of a rare thing for us to find pure vitamin B12 deficiencies in pregnancy itself, right? So what are the risk factors for women to develop anemia, right? Multiple pregnancies in the past, many pregnancies, multiparity, right? Poor diet, right? Postpartum hemorrhage, which has had in the previous pregnancy, antepartum hemorrhage in this period, and different kinds of, say, worm infestations are very rare, but sometimes there may be reasons for them to have iron deficiency anemia in pregnancy, right? So those are the risk factors that you need to look for. Okay. So basically, I have covered iron deficiency anemia to the up to the what you all require to know, right? I've touched on folate and B12 deficiency, and then we will look at the haemoglobinopathies and everything else, right? Other genetic disorders, right? At a later date for this. Okay. Right? Any questions? In primary pregnancy, do we need to increase the iron dose? No, we just leave it like that, right? We don't increase it, because the more iron, dosage you give, that doesn't increase the absorption, right? So this is the probably the optimal dose between 100 and 200, because even if you give more, what will happen is the gastrointestinal symptoms will increase, right? And she will not be compliant, because if she is having nausea, vomiting, discomfort, right, constipation, all that, she's not going to take it, right? So therefore, and just because you increase the dose of iron does not mean that the iron absorption increases, because iron absorption is only a limited amount. Because if you all remember, the epithelium has crypts, right? And there's a special iron binding protein, so the crypts go up and down and they change, and therefore it's only the limited capacity, especially in the duodenum, that the iron absorption can take. Just because you increase the dose doesn't make any difference. Why universal iron supplementation is started after 12 weeks of PO? It's the reason which you do is, number one is women come to us around 10 to 12 weeks. Okay. So the second thing is, naturally they have emesis or hyperemesis gravidarum anyway, right? So if you're going to give iron on top of that, it's going to increase constipation, it is going to increase vomiting, nausea, which is going to increase problems with the gastrointestinal symptoms, right? So therefore, we start iron after 12 weeks. I forgot to tell you the symptoms. Of course, remember, symptoms to diagnose clinically is what? Clinically, she must be maybe pale, then she might be lethargic, right? Dizziness, all that other normal symptoms of anemia which you have. So these are all non-specific symptoms. What are the indications for 5 mg folate supplement in pregnancy? Right. 5 milligrams normally indications are, if there's a past history of gestational diabetes, we give 5 milligrams, right? Because we think that there is increased amount of neural tube defects, and therefore to prevent that also the consumption is more. If the patient had a past history of any form of fetal anomaly, we give 5 milligrams, right? The third is, if they are on antipsychotic drugs, we give 5 milligrams. The fourth is, if they are on anti-epileptic drugs, because the consumption is higher, we give 5 milligrams. If there's any reason to suspect that they have a folate deficiency, like a megaloblastic anemia, which may be undiagnosed, we give 5 milligrams, right? So those are the normal reasons that we will increase that. Why ferrous is better than ferric? It's thought that the absorption, due to its atomic composition, the absorption has been found to be better in ferrous than in ferric, right? Is iron given to lactating women, and can iron deficiency anemia can cause postpartum rather than worsening it? Well, that's a very controversial point, right? Yes, iron is given to lactating women because the consumption is high, right? So therefore, iron is normally continued about 1 year until they finish breastfeeding on it. Normally, it can be continued for 1 year, right? In Sri Lanka, probably it's advisable maybe to continue iron, right? But however, it is absolutely not necessary. You can do the full blood counts, and if there is no anemia, you really don't need to give iron supplementation, right? Can iron deficiency anemia itself can cause PPH rather than worsening it? So that's the controversy. See, iron deficiency anemia will reduce the iron stores in the body. Iron is required for all the iron-containing enzymes, which has a role in muscles, the nerves, the epithelium, different kinds of functions. So we do not know how much it contributes. Deficiency contributes to PPH, right? But definitely, so because it's very difficult to find out, or there is no evidence to us tell you that okay, iron deficiency causes uterus to contract less well, okay, right? It shows that the nerves that go along the uterus is not functioning well, so therefore we have a PPH. It's very difficult to find those things out. What we know is, right, as clinicians, if you have a PPH in a woman with 6 grams per deciliter, she'll be worse off than a woman who starts with 12 grams per deciliter. Okay, that definitely we know. So therefore, definitely it worsens it, right? Whether ionization anemia can cause PPH, there is not much evidence. Okay, so associations may be there. What will we do if patient is on methotrexate therapy, right? Methotrexate therapy, methotrexate can cause fetal anomalies. Okay, so we normally do not advise them to get pregnant. Okay? They get pregnant, we will have to modify or stop methotrexate. Okay, and of course we will have to give increased dose of folic acid, but that is not in methotrexate. On methotrexate, you can have fetal anomalies, right? What are the out of values if HP in? What are the cutoff values of HP in mild, moderate, and severe? These are, there are no specific classifications, children. These are all clinical classifications of mild, moderate, and mild. So anything less than 7 or 6 can be. So there are different. India classifies it differently. So it's very, very difficult to say what is mild, what is moderate, and what is severe, because it has no clinical significance. Okay, in a woman who is having 7 grams per deciliter, right, may be very symptomatic. And sometimes if the woman has been anemic for a long time, she may not be symptomatic, right? So therefore, calling in mild, moderate, or severe has no huge clinical significance, right? Sometimes the women are used to a 5 grams per deciliter, they are fine on it. And if it drops to 3, they suddenly have problem. But women who are at 12 and drops to 6 or 7 or even 9 may be symptomatic. Do you understand? So trying to clinically classify between mild, moderate, and severe is not a very good clinical option. What we have to do is to what? We need to decide the point of treatment. Okay? And the point of treatment universally is if it is less than 10.5, which is anemia. Okay? Plus, the point of treatment, especially for blood transfusion and further interventions, even if it is 7 or 8 or 9, is dependent on the clinical situation. If she is symptomatic, that is the point of treatment. Do you all understand? Right? So you don't say, okay, she has 6, severe anemia, treatment. She has 8, moderate, no treatment. Because the woman who is 6 may not be symptomatic, while the woman is 8 may be very symptomatic. So if we rely on classifications to dictate our point of treatment, we are in trouble and the woman is also in trouble. Okay? If you look at classifications, anything over 10.5 is normal, right? Between, say, 10 and 9 would be moderate, right? Between less than 7 would be severe. Between 7 and 9 would be the other way around. Less than 7 would be severe. Between 7 and 9 or 9 also would be moderate. Between 9 and 11 would be mild anemia. Okay, but remember, children, don't think about those classifications like that. That is what I told. Okay, so if you ask how do you classify anemia, you just say it's all dependent on the symptom. There are different classifications, but however, it has to be correlated with the clinical findings, because we are talking about the point of treatment, not the classification. What should the target hemoglobin level be at term? As I told you, during the whole term, it's 10.5, right? Hopefully less than, it should be more than 10, okay? 10.5 is good, right? How decide whether double dose of iron is needed and usually how long it's given? Iron is given till the end of the pregnancy. Double dose is if our desired levels are not being reached, plus if we don't have much time, then we can give double dose iron. Remember, even if we double the dose of iron, that does not mean that the increase is double. Okay, so therefore increase might be just slightly, or maybe from 0.8 grams per deciliter in 1 week, it might go up to about 1.2, 1.1 grams per deciliter. The increase is not much even if you double, but the side effects will go up. Okay, so you need to balance that. How long does it take oral, IM and IV to correct anemia? As I told you, oral 0.8 grams per deciliter, it will go up. So if it is from 6, you are climbing up, then it will go up by roughly 1 gram. Okay. So every week, 0.8 grams or 1 gram, it goes up or down. You can calculate that yourself. Intramuscular, in IV is very quick because you are going the stores. You are increasing stores very rapidly, right? And the body will start with the erythropoietin and start making. So within 1 week or so, it will go up fairly quickly. Okay. Is there a cutoff limit of hemoglobin for transfusion for whole blood? No. That's all. The point of transfusion, right, is if she's symptomatic. Of course, anything below 7, we will think of transfusion, right? But even at 8 or 9, if she's symptomatic, we might think of transfusion if she's very much near the delivery, right? Right. There's a lot of questions. Okay. Okay, I think we have ended with the questions. Okay, good. I hoped it was going to be a short session. Ended up answering a lot of questions. Right, okay. Okay then, I want you all to, I think we have to do the malignancies, I think, right? That's what you all want, right? For gynecology. So now we did the pre-malignant. So then, so no ovarian CA like that. If you want that, please indicate, please type it into the forum, right? What topics you want covered, because even anemia I chose from one of the messages I got into the forum. Okay. Okay. Good night.
Good night.
Good night, sir. Thank you.
Thank you, sir.
Thank you.